Good. Welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ. Tonight we're talking about lobular breast cancer, one of the less common forms of breast cancer, but still affecting around 500 Kiwi women a year. So what is lobular breast cancer and what makes it different? Well, that's what we're here to find out. And we have two panelists who will share their knowledge and experience with us. Let me introduce you. With me here are patient Anna Stove and medical oncologist Dr. Sheridan Wilson. Thank you both so much for joining us. Now, before we get started, some housekeeping. I probably need to start my slides, Anna. Okay, thank you. Get that going. So first up, a warning, as you can see already, this is our first webinar using Teams instead of Zoom, so things are slightly different and we're just getting used to the technology. It might also look a little bit different on your end if you're used to our webinars, but hopefully you and we will figure out any challenges. But if you do have a problem, click on the chat icon and ask for some help, and our support team will get in touch. You can use the chat box during the webinar to ask questions, which we'll get to later, and you can also chat to other people there. Don't worry about missing out on information while we're talking. While you're talking, the webinar is being recorded and will be available on our website tomorrow. So let's get started. First, we're going to hear from Anna Stove. She was diagnosed with lobular breast cancer in 2021 at age 57. Anna, thanks for being here tonight. Tell us a bit about your story, how you were diagnosed and what happened from there.
Lovely, thank you. Thank you, Adele. So good evening, everyone. My mother had breast cancer when she was 40, so I've been having mammograms since I was about 35 years old, and I've never had any issues. However, about 2.5 years ago, they found a lump in my left breast during a routine mammogram. When I was called in for a biopsy, the clinical breast nurse also noticed some dimpling on my right breast. You could actually only see the dimpling when I was sitting. An ultrasound and biopsy confirmed I also had cancer in my right breast. And if it hadn't been for that amazing nurse, Fiona, who saw the dimpling, and I will never forget her name, it's likely the breast cancer in my right breast wouldn't have been found probably for another 12 months. Normally at this stage, you'd be told to come back the following week to get your results and not to worry too much. But because of what they'd seen on ultrasound in both breasts, they told me to come back with a support person and we would need to work out a plan. The diagnosis was two different cancers, a ductal carcinoma in situ and an invasive lobular carcinoma, but both were hormone receptor positive, so would be treated the same way. The recommendation was to have a bilateral mastectomy, and I was encouraged to have reconstruction at the same time.
And bilateral, that means both breasts?
So both breasts, yeah. So as I said, I had two different cancers, one in each breast, and the recommendation was to have both breasts removed. And I was encouraged to have a reconstruction at the same time, which was going to be a 12-hour operation. The only highlight of the operation was that they actually took my tummy and put it into my breast tissue. So I managed to get a tummy tuck out of it, which was pretty exciting. As I was keen for it to happen quickly and we had private insurance, we made the decision to move from public to private to speed things up. However, my first consultation with my breast surgeon was the night New Zealand went back into COVID lockdown in August 2021, and private hospitals the next day were shut for 7 weeks. So during that wait, I had several scans and tests, and an MRI confirmed staging of the lobular breast cancer, stage 2, grade 2, invasive lobular carcinoma. Emotionally, I found it very hard waiting without having a surgery date. Even though my breast surgeon rang me every week for a bit of a chat and a catch up, that didn't seem to help. I have a medical background and knew that a couple of months wait wouldn't actually make a difference. However, I got totally stressed out by it. A girlfriend of mine who's a breast nurse and extremely practical told me to just think about what if my initial mammogram had been delayed till later in that year and I would have been none the wiser. And I think just a few discussions like that really helped me to put things into perspective. When I eventually had my operation 7 weeks later, due to COVID restrictions at the time, my husband had to drop me at the front door with security guards. It was the first week that Ascot Hospital had reopened, and there were only 6 of us in the entire hospital. It was like a ghost town. However, I received the most amazing care from the healthcare team, and although I wasn't allowed any visitors, not even my husband, this actually helped me recover. I was out of hospital within 5 days. As I was hormone receptor positive, my treatment following my mastectomies was endocrine therapy. It was decided by my medical team that I would not need chemotherapy or radiation. I'm on a 5-year course of letrozole, and this decreases the amount of estrogen produced by the body, which can slow or stop the growth of breast cancer cells. As I wasn't in menopause and was still having my periods, I also needed monthly gossarin hormone blocking injections for 2.5 years. I still remember Sheridan, and actually Sheridan is my medical oncologist. I still remember Sheridan saying to me that she needed to put me into menopause. And when I asked, when will this happen? She said, tomorrow. I've also had 6 monthly biphosphonate IV infusions, and my last one of these is next month, which is meant to reduce the risk of cancer spreading into my bones. So where am I now? I see my breast surgeon and my medical oncologist once a year, and this is staggered so that I get to see someone from my team every 6 months. I've still got about 2.5 years of letrozole remaining, and this little tiny tablet can cause quite a few side effects. They do for me, probably not for everyone. They're menopausal-like side effects. For me, it's been mainly fatigue, brain fog, dizziness, and heat. And although some people say these side effects usually improve, I actually think you just get more tolerant. I'm at an age where all my friends are in menopause, but the majority are all on HRT to help with the symptoms. And obviously when you're on a breast cancer journey, you can't take HRT. What helped me most with my recovery post-surgery was lymphatic drainage massage, Pilates, and swimming. I'm extremely lucky that I have great movement with both my arms and no swelling, and I put it down to these 3 things. 2.5 years on, I'm doing brilliantly. I just sometimes need to remember and remind myself I can't go 100 miles an hour all the time like I used to. If I need an afternoon power nap before a meeting, I take one. I do my board paper reading early in the morning when my brain is at its best. It's so important to look after yourself during this journey. As the Air New Zealand safety video says, you need to put your own oxygen mask on first before you can help others, something women aren't very good at. Thank you.
Well, thank you so much, Anna. That was really great. And we really appreciate you sharing your experience so openly. A reminder to you folks at home, don't forget to use the chat box to talk to each other or to submit questions, and keep an eye on the conversation. Right now we're going to hear from medical oncologist Dr. Sheridan Wilson, who works at Auckland City Hospital and also in private practice in Auckland. Sheridan, thank you so much for joining us. We really appreciate you making the time. What exactly is lobular breast cancer?
Yeah.
What makes it different?
All right, so we're going to cover a whole range of sort of characteristics of lobular cancer. There'll be some people who've never heard of lobular cancer before because it is the 2nd most common type of breast cancer. In New Zealand, the rates are about 10 to 15%, and this is similar to the rates around the rest of the world. So we're not an outlier in any way, but you'll see that for the 2nd most common type of breast cancer, this is still relatively rare compared to the more common ductal variety of breast cancer. We do see it slightly more commonly in older women, but generally the risk factors for lobular breast cancer are the same as for an invasive ductal breast cancer, which is the other kind. So that includes things like high alcohol consumption, obesity. There's a relationship between lifetime exposure to estrogen. So for that reason, things like age at getting someone's first period or age at first childbirth are associated with breast cancer risk. And those two are particularly more associated with lobular breast cancer for reasons that we don't fully understand. And whilst invasive lobular cancer is not a common type of breast cancer for those who have an inherited risk for breast cancer, there is a particular genetic alteration that is more associated with lobular cancers, and that's called a CDH1 gene alteration. So it is very rare, but that is the genetic alteration that we can see associated with lobular cancers. Most lobular cancers are not related to an inherited gene risk. So what do I actually mean about by lobular cancer? So some people will have heard about breast cancers being described by subtype. There are different ways that we can characterize breast cancer. We can talk about the histological type of breast cancer, and that's where we get the phrases invasive ductal cancer, invasive lobular cancer, and then the other ones. And a histological type of breast cancer is really about how it looks under the microscope. So when a pathologist receives a sample from a breast biopsy, or they receive the surgical specimen after someone's had their breast surgery, they spend a lot of time doing special stains on the samples, looking down the microscope, and through that process, they're able to define the cancer as a ductal or a lobular cancer. In fact, the biopsy may have given that information as well. The other ways that we think about ductal cancers is partly about their arrangement, and again, the pathologists are looking at this down the microscope. What you might see is that the ductal cancers, which are at the top of this slide, the purple cells are the cancer cells, so they look like purple dots, and they're arranged in sort of clusters or nests, whereas the lobular cancers, which is the picture at the bottom of the slide, the purple cells, which are the cancer cells, are more arranged in a line or a single file pattern, and they're more sort of dispersed through the pink background. So that's what makes lobular cancers special, is how the cells are arranged. The reason that they are sort of dispersed in this single file way is related to one of the molecular alterations. So a molecular alteration is a change that's happening deep in the molecules of a cell. And what causes the lobular cancers to appear this way is that those cancer cells have lost a molecule called E-cadherin. And E-cadherin is the molecule that helps cells to stick together. So if the cell doesn't have that, the cells don't stick together so much, and that's why we get this pattern of cells drifting through tissue rather than clustering as a nest or a sort of a coalescence of cells. Lobular breast cancers are usually grade 2, so all breast cancers are graded, and grade is not the same as stage. People do often get those two things a little bit muddled up, but the grade of a cancer is again related to how it looks under the microscope. So that's something that a pathologist will tell us. A grade for a breast cancer can be 1, 2, or 3, but lobular cancers are pretty classically grade 2. And they're usually hormone receptor positive.
So Sharon, we usually talk about grade being a sign of sort of how fast growing or aggressive the cancer.
Yeah, look, I guess that's one way to think about it. It's not the only thing. A grade is a score, and the pathologist's looking at a few different things. But it's true that a grade 3 cancer is typically a cancer that is able to grow faster, whereas a grade 1 cancer, they typically are more of a slow growing phenomenon. So people often think about grade being a marker of aggressiveness, which is not an unreasonable way to think about it.
And Annie, you were right there in that grade 2.
Yeah, I had that too.
You were the classic.
I was the classic. Nothing exciting more special.
Lobular cancers and other breast cancers, the ductal cancers in particular, we're interested in what we call the biomarkers. And by that I mean the estrogen and progesterone receptors, and also the third receptor, which has nothing to do with hormones, which is HER2. So a lobular cancer is almost always hormone positive, but I say almost always because lobular cancers can also be hormone negative and they can be HER2 positive as well. That's just very, very rare. There's another way to classify breast cancers, and that's at a molecular level. So some people might have had extra testing done as part of planning their treatment and been told that they had a luminal type of breast cancer, which really means that the cancer is hormone positive, and most breast cancers would fit that category. We use the same staging system for lobular cancers as for ductal cancers. Stage is really about the burden of cancer or how much there is. So a stage is calculated based on how big the tumour is and whether there are lymph nodes involved. So that same system applies for lobular breast cancers as well as for ductal cancers. You heard in Anna's story that she had DCIS in one breast. So DCIS is nothing to do with lobular cancer. It's ductal cancer in situ. Now, the key difference in ductal and lobular cancers in terms of where they originate from is that the ductal cancers originate from cells that are lining the milk ducts, whereas a lobular cancer originates from cells that are lining the lobules of the breast. That's where milk's actually produced. And if a lobular or a ductal cancer is described as in situ, it means that the cancer has started to, or cancer cells have started to evolve in that area, but they haven't developed the potential to invade the surrounding tissue. So they're kind of contained. They're not considered invasive cancer. But if the cells have continued to evolve and develop the potential to invade the tissue that's surrounding the duct or surrounding the lobules, then it's an invasive cancer. A lobular carcinoma in situ is something that often doesn't show up on a mammogram or anything like that. It's often found just alongside other features in a biopsy. And it doesn't actually, doesn't necessarily move to an invasive lobular cancer in a step-by-step pattern. But if a biopsy has shown lobular carcinoma in situ, LCIS, it does suggest that that person is at risk of a breast cancer, which can in fact be any type of breast cancer. So it's more of a marker of risk in a breast rather than a precursor or a beginning of invasive lobular cancer. Lobular cancers can be hard to diagnose. They don't always cause the typical changes in a breast, and I think Anna's story really indicates that. Once you've looked at the pictures about how a lobular cancer grows, you can understand that cells that are trickling through breast tissue might not necessarily cause a lump that anyone can feel. They can also be harder to spot on a mammogram for that exact reason. So the symptoms of a lobular cancer can be a bit vague. It can be thickening or hardening in a breast. It might be the dimpling that was spotted in Anna's breast. It could be a change in shape. It can also be a lump, but these other patterns of breast change are a little more common with a lobular cancer. As I've said, lobular cancers can be harder to spot on a mammogram because they're not causing the same distortion in the breast. But that doesn't mean mammograms have no role in screening for lobular cancers. They're still our first step in screening for breast cancer. If someone has an abnormality in the breast, like dimpling or another change, they won't necessarily go have a screening mammogram. They instead would have diagnostic imaging, and that's slightly different. So with diagnostic imaging, there are there's the availability of doing extra views of the breast, and there's often the availability to do an ultrasound at the same time. And for for lobular cancers, women are frequently considered for an MRI scan as well, and that's really just as a way to try and get more information about the sneaky lobular cancer pattern, because they have that smaller single cell type arrangement. They're not going to cause distortion in the breast, and they're slightly more likely to appear in more than one part of the breast. So you might hear words like multifocal or multicentric, and this means that there are spots of cancer in more than one part of the breast. If it's multifocal, it means it's in the same quadrant of the breast, and if it's multicentric, it means it's in two different parts of the breast. And that's an important thing to know about when surgical planning is happening. Some people might have heard about lobular breast cancers being more likely to be bilateral, as Anna said, that's having cancer in both breasts. Well, traditionally, that's what we thought. We thought that lobular breast cancers were more likely to be seen on both sides, but actually that's not consistently demonstrated in the information from around the world. So probably not a big difference in the likelihood of having cancer in two breasts with a lobular cancer. So imaging the breast for a lobular cancer, it will include mammography, it might include ultrasounds. Neither of these are perfect, and often MRI scans are part of the breast imaging plan if someone has had a biopsy which shows lobular cancer.
Is that an ultrasound just the breast, or
and to look at the lymph nodes under the arm as well. So the lymph nodes under the arm can often be examined simply by feeling under the arm, but ultrasound's a really good way to look at that area too. The other time we think about staging of lobular breast cancers, and here I'm using the word staging in a different way. I'm not talking about how big is the cancer and is it in the lymph nodes necessarily. I'm talking about taking pictures that might uncover other parts of the body, like the bones or the lungs or the liver. So we talk about staging investigations if we're trying to look beyond the breast area to establish if there are lymph nodes that are in another part of the body, or if there's trouble in another part of the body that might be related to cancer. And we consider these staging investigations, which can be CT scans or bone scans or PET CT scans. We often think about doing those if someone's got a really a large number of lymph nodes involved. So if there's a lot of lymph nodes involved, that increases the chance that there might be trouble elsewhere that we need to know about. One of the tricks with lobular cancer, just like it's hard to see in the breast, can be quite hard to see on staging scans as well, if the areas that are involved by that fine spread of a lobular cancer rather than a lump somewhere. And there's quite a bit of interest at the moment in developing imaging tools or scans that are specific for lobular cancers. And there's different strategies being tested in clinical trials to figure out if there's a better way to look at lobular cancers. And we're going to be doing one of these types of studies in New Zealand a little bit later on in the year, looking at a particular type of PET scan, which is going to be specific for people who have a lobular cancer that is already involved the lymph nodes. So just to clarify, a PET CT scan is a little different from a plain CT scan, because as well as having a CT scan, which is a fairly standard radiology scan where you get cross-sectional images of the body, with a PET CT scan, there's also an injection of a tracer that will then target or go to certain parts of the body, depending on what that tracer is sort of targeted to. So most PET CT scans in New Zealand use a tracer that's linked to glucose. But the interest in the lobular staging is to find traces that you can link to a molecule that's specific for a lobular cancer. So that's a bit of a watch this space area. The surgical treatment for lobular cancers isn't necessarily different from the surgical decision-making or plans that are undertaken for a ductal cancer. And there's lots of different factors that will influence the surgical decision-making, particularly the size of the cancer that's in the breast, which part of the breast it's in, whether it's known that there are any lymph nodes involved, and of course what the surgeon and the patient decide is right for them. We do know that with lobular breast cancers, there's a slightly higher rate of the margins being involved, and so that's when the tumour's taken out, there's still a bit of cancer at the edge and a second operation might be needed. But provided with the surgery that is undertaken, those margins are ultimately clear, there's no higher risk of cancer coming back in the breast with a lobular cancer. It's probably worth noting the role of radiotherapy is the same for both lobular cancers and ductal breast cancers as well. So typically radiotherapy would be mandated or an essential part of the treatment if someone has had breast conserving surgery or a lumpectomy. And it may also be recommended after a mastectomy if the tumour size is large or if there's lymph node involvement. Those would be the two typical reasons for radiotherapy after a mastectomy. The systemic or the drug-based decisions for a lobular cancer can be a little different because lobular cancers are almost always hormone positive. The hormone part of treatment or the endocrine part of treatment is really prioritised or really important for lobular cancers. So it would be a big part of the discussion with a medical oncologist. And we know that the lobular cancers are particularly sensitive to those hormone approaches or anti-hormone approaches, as I like to call them. But that doesn't mean that chemotherapy is never used. And so some examples where chemotherapy would be part of the discussion would be obviously if the lobular cancer was hormone negative, because in that situation, the hormone approaches are meaningless. They're not going to help. Or if the cancer has already spread to a lot of lymph nodes, sometimes in those situations, we bring chemotherapy into the decision as well. And if a tumour, including a lobular tumour, is HER2 positive, then the drugs that we would talk about are not just hormone drugs, but also HER2 drugs as well. Around the world these days, there are some extra tests that can be done to help in the decision-making around choice of drugs after an early breast cancer diagnosis. These are often called multi-gene assays or molecular stratification tools. And the brand names are things like Oncotype DX or Mammoprint or PAM50. Some people might have had those done. They are tests that look at a deeper level at the genes in the tumour itself to give a score that can help decide whether chemotherapy is a necessary part of the treatment. And we know that most lobular cancers come out with a low risk on these scores, which really just helps to confirm that chemotherapy isn't going to add any benefit. But those tools are not specific for lobular cancers. They're really just used in breast cancer generally.
And but those tools you have to pay to have them?
That's right. So they're not funded in New Zealand and they're thousands of dollars. So they can be ordered by medical oncologists in a hospital, in a public hospital setting, but they're self-funded tests. And we're very used to making the decisions without those tests, but sometimes we talk about them if we think they're going to add an extra layer of information that's important. So I'm just going to talk a little bit about the treatment for metastatic lobular breast cancer. So as with ductal cancers, sometimes in the future people will have their cancer relapse, and by that I mean spread to other parts of the body. In the past, there haven't really been any different drug-based approaches for the treatment of stage 4 or metastatic lobular cancer. We use the same decision-making process as we use for ductal cancers as well, which means thinking about where the cancers spread to, what we know about it from a biopsy, so is it still hormone positive, and what the burden of symptoms are for that particular individual. Because most lobular cancers are hormone positive, hormone therapy is usually the first step in treatment for metastatic lobular cancer, but there isn't a set of rules about the order that you do things. And so the decision making that happens when someone has metastatic cancer generally involves a process of shared decision making with an oncologist and a patient thinking about what the options are. It might be helpful to know that lobular cancer doesn't necessarily have a higher chance of becoming metastatic. The risk of a relapse in the future is not related to whether a cancer is a lobular cancer or a ductal cancer. It's related more to those features like grade and stage at diagnosis. The time course, however, for lobular breast cancer to come back can be a little different. So we observe that lobular breast cancers are a type of breast cancer that can relapse late. And they also have a slightly different pattern of spread if they do come back. So they can go to all of the same places that a ductal breast cancer can go to, but somewhat unusually, they can also spread to the surfaces that line around the outside of the lungs or the inside of the abdomen. I guess following those surfaces and doing that thin kind of trickle of cells that we also see in the breast, they can do in other parts of the body if a spread of lobular breast cancer happens. So what's new in lobular breast cancer then? Well, I think as the technology in the laboratory has become more widely used, there's been an opportunity for breast cancer researchers to really dive into some of the detail of lobular cancers. And so we know more about lobular cancers than ever before. We know that they've got some slightly different gene mutations, and that's led to the development of some clinical trials that are happening overseas, testing drugs that are specific for lobular cancers. And that's the first time this has happened because they are a relatively small group of cancers. There hasn't been a lot of specific research in lobular breast cancer until recent times. So what we're seeing now is the growth of clinical trials that are specific for lobular cancer, and that's going to give us information in the future about how we should adjust our treatment approaches. The other thing that's happening in lobular breast cancer at the moment, as I mentioned, is a further consideration in the best way to image or best radiology techniques to look for lobular cancer, both in the breast and further afield. So those are some areas where I think we're seeing changes at the moment.
Great, thank you so much, Jen. That was extremely informative and a lot for people to digest. So if you've got questions on what you just heard, please do go ahead and submit them now. And we're going to get on to a couple of those questions now. So first up, Sheridan, although as you say, most lobular cancers are hormone receptor positive, one of our watches tonight who has a triple negative lobular breast cancer. What are the sort of special considerations there?
Yeah, so in that situation, the features that are going to be the key driver of the decisions are the fact that the cancer is triple negative. So that's the key information rather than it being lobular. And so the drug-based decisions there will be in response to knowing that, well, a hormone approach isn't going to be valuable because the cancer is hormone negative, and the HER2-directed approaches are not going to be valuable. So it wouldn't affect the surgical plan, it wouldn't affect the radiation plan, but it would certainly affect the drug choices. And triple negative lobular breast cancers are going to be rare, but we still see them occasionally, much like the HER2 positive lobular breast cancers. Very rare, but we do see them.
Right. Okay, thank you. Now, our next question is around how there's someone who wants to know how come their 10-centimetre tumour wasn't seen on a mammogram and an ultrasound and really only picked up on biopsies.
Yeah. So lobular breast cancers can be underrepresented on our imaging for that reason around how they grow. So I often, if you've been in clinic with me, you've seen me do this. If you've got a volume of tumour cells that are going to cover this piece of paper, and that's sitting, and if my breasts were very large, sitting in my breast, that's not going to change the shape of my breast very much. And to be seen on imaging, there has to be some distortion. But if you take the same number of cells, and that's now in a lump, it's going to cause a really obvious distortion in the breast. So lobular breast cancers are often bigger when they're taken out than we actually realised, either by feeling them or by looking at them on imaging. So sometimes the lobular cancers have grown really big before they've been noticed, and that's how a tumour can get to quite a remarkable size without having declared itself earlier.
Right, wow. And how do you have a biopsy on something that's not visible?
Well, if it's
Multiple.
changes or dimpling like in the head, that's the area that would be targeted. But if there's sort of a suspicion that something's not right, but there's not a discrete or a well-defined area to biopsy, that might lead to other investigations like an ultrasound or a mammogram.
And so this, as this person says, if that couldn't be seen on a mammogram, how do you see if it comes back in the breast or in the other breast? Keep looking.
Yeah, so I think that the sort of topic that reflects is really what we call surveillance after breast cancer. So we know that for any woman who's had a first breast cancer, they're at slightly higher risk of a brand new breast cancer in the future, not necessarily a recurrence, but it might be an entirely different thing. And so screening tends to step up a notch after a first breast cancer diagnosis. And exactly what imaging is chosen to screen will depend on a woman's breasts. So we know that there's important considerations around breast density. Some women have really complicated and complex breasts that have been hard to find anything in. And in that situation, their treating team, which includes breast radiologists, might recommend a different strategy, not simply relying on mammograms. But mammograms are a good tool, and you're looking not just for something exactly the same as the first breast cancer. You're looking for all the other things that can happen in a breast as well. So they shouldn't be discounted as a good option for screening.
Great. Okay. And quite a few people have chipped in to say thank you to you for sharing the story. Pleasure. Very helpful. Thank you.
Just when you were talking about trying to biopsy for a lobular, I think I had 13 biopsies in the one breast when they found it that time. Like let's just keep going. I mean, I felt like I'd sort of done a round with Mike Tyson afterwards. I was just black and blue, and they were doing it under mammogram and also just doing it with the radiologist. But so I think, and I didn't know why at the time. Like I just thought, wow, they're taking a lot. But maybe that was the reason, because they thought this is probably lobular, and yeah, we'll just.
And maybe didn't, although you had the dimpling change, maybe couldn't see on any of the imaging where to target.
So yeah, I really was just a dart, I think. Yeah.
Got you where you needed to be.
Yes, exactly. Exactly. It was just like go for it.
System wedge. On the subject of PET scans, someone's saying after having lobular breast cancer, can you pay privately for a PET scan for reassurance if you didn't have one?
So PET scans, a few things to say about that. PET scans are not easily accessible throughout the country. The technology and the equipment and the expertise that's required are at the moment clustered in a few areas. And there has been some concern that maybe plain PET CT scans might not be the best type of scan for a lobular cancer. So I would counsel anyone to have that conversation with their oncologist, who will be able to give them a bit more information about what's available in their area and what the pros and cons are. We try and only do staging with PET CT scans or CT scans or bone scans in situations where it's going to make it, where we think there's a higher risk of finding something that's already spread distantly, or if someone's got symptoms, because there is a risk of finding things that lead you kind of down a rabbit hole and lead to extra biopsies and a lot of worry. So it's a decision that needs to be made together with the medical team, so that you know what the risks and benefits of the pros and cons are. I guess the short answer is yes, you can pay for scans, but you need somebody to order them who knows what they're going to do with the information, and you need to go into that decision with the right information as well.
Yeah, that's helpful. A question around bisphosphonates. Someone similar to Anna, who had hormone receptor positive cancers on both breasts and was 48 at the time. One of the lobular tumours was 67 millimetres. I had chemo and radiation after bilateral mastectomies, but bisphosphonate infusions have not been mentioned. Should I be asking for this?
Yeah, so bisphosphonate, what a bisphosphonate is, it's a drug that, actually they're drugs that are mainly used to treat osteoporosis. So we've had them for quite a long time, initially in a tablet form and then in injected forms. And we use them in the cancer world for two different reasons. In two different situations. We use them if someone has had breast cancer come back and it has spread to the bones, because it can help reduce the chance of pain or fragility in the bones or needing radiation. It can also help manage calcium if they're really high, if it's really high in the setting of advanced or metastatic breast cancer. But in the setting of early breast cancer, which is Anna's situation and sounds like the situation of the watcher, the bisphosphonates are given partly because they can reduce the bone thinning that estrogen lowering medicines cause, but arguably more importantly because they reduce the chance of bone metastases, and that's when breast cancer has spread to the bone. And in that way, they can improve the long-term outcomes after early breast cancer. The drug that we most commonly use is called Zometa or zoledronic acid. It's as an intravenous injection, so that's a drip in through the vein once every 6 months for 6 treatments. It's not the right thing for everyone because there are some side effects that make it unsuitable for some people. And the first infusion can cause quite a lot of side effects. So increasingly we use that medication. We try and start it early. There will be some people for whom it's just not appropriate. And it's not clear whether if you introduce it later down the track, so years later, it's not clear whether it has that same benefit in reducing the chance of breast cancer spreading to bone, but it probably still has some benefit in terms of bone strength.
So for that viewer and for another one who's also said she's on anastrozole, but not offered infusions, is that something they should discuss?
They should, but the discussion would be, I guess it would be something like, I know these drugs can cause some bone thinning, and I know that's the anastrozole or the aromatase inhibitors, and I know some women have bone infusions as part of their treatment. Is that right for me?
Yeah. Great, thank you. That's useful for people to take to their next appointment. Do you think there will be changes to treatment options in New Zealand for hormones? That's quite a more general question for hormone receptor positive breast cancers, such as available overseas.
So at the moment, there's one key drug that is used in the setting of early hormone positive breast cancer that's funded in Australia and not funded in New Zealand. And it's an add-on drug that gets given as well as a drug like letrozole or anastrozole. So that, and it's particularly for higher risk breast cancer.
Is it available here?
You can pay for it here. You can. So it's registered for use, which means that it can be prescribed by a doctor, but it's not funded by Pharmac, so you're out of pocket for that, and it's thousands of dollars per month.
Is it on the government's 13 cancer list? No.
It's not. No.
It is on a high priority on the options for investment list, or it's only on the options for investment list.
It's one of the drugs we've made a bit of noise about, and to be fair, it was only funded in Australia on the 1st of May, so it's not like this is something that's been available for a long time elsewhere. But I think my honest answer to that question is yes, I'd like to think that there is the addition of these drugs when their benefit is proven. Takes a while in breast cancer to know that something makes a difference. And sometimes when you get the early results of a study, you have to just be patient because it can take a few more years to be sure sometimes. And the addition of these drugs in the early breast cancer setting has been a little bit like that. We've been watching to be sure that they really make a difference, and it looks like they do.
That's exciting.
Yes, it is. It is. Someone who had high-grade DCIS 10 years ago, lumpectomy radiation, then an invasive lobular cancer in the same breast 10 years later. Is this a recurrence of the DCIS spread to the lobules, or is it new?
No, new.
Yeah,
new, a brand new thing.
Yeah, yay.
And so that DCIS doesn't become lobular cancer.
Great, thank you. And what's the significance, speaking about these drugs that prevent cancer coming back, so what's the significance of getting to the 5-year mark after a cancer diagnosis?
Yeah, I don't know. I think it's probably my honest answer. We think a lot about 5 years because the majority of the breast cancer studies for the hormone therapies used 5 years of treatment, but there are definitely some situations where we go longer than 5 years. And there are sometimes we go up to 10 years of hormone therapy, depending on the characteristics of the cancer. I think in the past, and I'm talking decades ago, when the outcomes for breast cancer weren't so good, relapses tended to happen earlier. And it's true that for the most aggressive breast cancers, which are typically the hormone negative breast cancers, they do have a higher rate of relapse in the first 5 years. But for the hormone positive cancers, the pattern's a little different. So I think the significance of 5 years is really for some women, it means they get to come off a pill that they might have been on, but there isn't a magic point in time where the risk of a breast cancer hits 0. So that 5-year moment is probably a little bit historical.
I think that's a little different, say, with bowel cancer, where most of those recurrences do happen in 5 years. So just because someone, that is not the same thing necessarily in cancer.
And different for different types of breast cancer.
Absolutely. Yeah. Let's see. And in fact, that brings me back to something you said earlier. You talked about lobular cancers being more likely to have a late recurrence. So late means 7 years after diagnosis. What kind of, how late is late?
So it can be 10+ years late, actually, which is probably a bit of a confronting thought for some people. And it doesn't mean that everyone's going to have a relapse after 10 years. Please don't go away thinking that. But just the time course or the pattern with a lobular cancer is different. So we see more late relapses with a lobular cancer than we do with a ductal cancer.
So quite hard to hold that in your head, isn't it? That you don't want to be worried about it every day or anything, but to also think that if you did have some symptom 10 years later, don't ignore it.
Yeah, I think that's an important point, is that anybody living beyond a breast cancer diagnosis can't change their history. So if you become unwell for another reason, it needs to be on the list of considerations.
Is follow-up with lobular different follow-up with ductal
No,
because of that reason?
no, I can see why, you could argue that it should be, but I think what's more important is there's an awareness that late relapses can happen so that symptoms aren't dismissed. Yeah.
Someone here is just saying they're about to have a hysterectomy with their ovaries removed. Does having no ovaries help prevent recurrence?
If the ovaries are being removed as part of a hormone strategy,
It's due to the thickening of the endometrial wall.
right? Okay, so the short answer is no. But there are many women, like Anna at the beginning, having the goserelin injections, which is to reduce the ovarian production of estrogen. And so removing the ovaries is the other way to achieve that. So sometimes taking the ovaries out is actually part of the hormone strategy, in which case it does reduce future breast cancer risk because it's part of that treatment program. Lobular cancers are slightly more likely than a ductal cancer to spread to the reproductive organs, but actually, unless you carry a genetic mutation that puts you at increased risk of an ovarian cancer, removing the ovaries isn't a standard part of reducing risk.
Right, okay.
Probably a bit confusing because there's a few reasons why you might have it done. There's something looks abnormal, or it's part of your treatment program, or you carry gene risk.
Right, okay. Actually, a really pertinent question from someone in Hawke's Bay who doesn't actually have an oncologist, and so questions tend to go to the GP and then sort of funneled through to someone else. I guess there are actually quite a few places around New Zealand where people might not have seen an oncologist like you for their lobular breast cancer because they're on that hormone treatment that could be prescribed by somebody else.
Yes.
Yeah, so what's the story?
Yeah. So there's different patterns around the country. So some surgeons prescribe endocrine therapy or hormone therapy. Sometimes it's prescribed by GPs, but the decisions about whether or not it's the right thing to do include a medical oncologist. So those decisions generally happen in a multidisciplinary environment where there are radiologists, surgeons, medical oncologists, radiation oncologists, and cases are discussed in a treatment plan proposed. The other thing that is always available is advice. So if a GP is overseeing someone's hormone therapy, they can always contact a medical oncology unit or the original surgeon for advice about changing tablets or when to stop. Even though a medical oncologist might not be offering a regular appointment, we still have referral systems to provide that advice.
Great. And people who are still under the care of a surgeon can contact their breast clinic to ask those questions. Yeah, great. Just another quick question about bisphosphonates. Are they not recommended when someone's on tamoxifen?
No, they are still often part of the treatment for that bone spread protection. Even tamoxifen has quite different effects on the bones compared with the aromatase inhibitors. So in post-menopausal women, tamoxifen actually helps with bone strength, but you might still be considered for a bisphosphonate because of that reduction in the risk of cancer spreading to bone.
Great. Okay. The CDH1 gene you mentioned, do people get tested for that?
Only if there's a really strong family history. So the other cancer that is associated with that gene abnormality is hereditary diffuse gastric cancer. And so if in the family, which is a particular type of stomach cancer, if there's a family history of lobular breast cancers and that type of stomach cancer, then that would be a flag to test for that gene. Now, in New Zealand, there are some families that know they carry that gene, and so they're able to then have other family members tested.
Right. And people who are interested in the multi-gene kind of tests that you talked about, when testing their tumour, is that can a surgeon order those tests, or do they have to be
generally ordered by a medical oncologist because it's about drug-based decision making, and there's certain criteria that you certainly wouldn't do a test like that in a lower risk cancer. So in Anna's case, we probably didn't even talk about it, not relevant. There's enough information to make a good decision. But there will be some scenarios where that decision around, is chemotherapy really, we think we're doing chemotherapy, but is it really the right thing to do? There might be a role, and that could be the discussion with the medical oncologist. It happens early, so it's a test that needs to be done before you finalise a drug-based treatment plan.
Okay.
It's not something you would do later on. It wouldn't be helpful.
Right. Yeah. Just a question around recurrence being more likely in premenopausal or postmenopausal.
So I can't answer that specifically in respect of lobular cancers because the numbers are too small. So when we're diving into the detail of breast cancer in young women, and so by young I mean under 40, then the number of women under 40 with breast cancer is so much lower than the number of women over 40 with breast cancer. And so then if you take just 10% of that, you're starting to talk about small numbers, which means that it's very difficult to have accurate data.
And you said older women tend to have more.
That's right. Lobular cancer is a bit more common in older women than it is in younger women. We do know, if we talk about breast cancer more broadly, not just focusing on lobular cancers, we do know that the breast cancers in younger women do probably behave a bit more aggressively, and we tend to respond a bit more. So there's often more treatment considered for younger women than for older women in response to that acknowledgement.
Yeah. Great. Okay, I think we're just about there. Yeah, I think we've covered everything off. Right, okay, so we will leave it there for tonight. Thank you everybody for joining us. Thank you again to Anna and Sheridan. You've been fantastic, and thanks also to our producer Hannah, who's kept us all under control technically. We hope everybody at home found this helpful. Tomorrow we'll send you a link to watch online, or that you can share with other people who might be interested. We'll also send you in that email a link to an extremely short survey where we'd really appreciate your feedback. It would take you less than a minute to do. If you have any questions about breast health, you can see on your screen there our nurse advice line, our nurse support line. Feel free to call that tomorrow or anytime during office hours. And we have our online MyBC community there too for people who've been diagnosed with breast cancer. Thank you again for joining us. Ka kite.
Good questions. Don't look like a thing. It's a free. Yeah.